Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the anatomy of the rotator cuff, also called musculotendinous cuff of the shoulder. What is rotator cuff? The rotator cuff is a fibrous sheath formed by four flattened tendons which merge with the fibrous capsule of the shoulder joint and makes it stronger. So we have four tendons, one from the supraspinatus, another from infraspinatus, another from the teres minor, and the last one is the subscapularis muscle. Okay, so we got the supraspinatus, infraspinatus, and the teres minor, and also the subscapularis. Teres minor is not shown here. It is underneath, just below the infraspinatus. Okay, so the following muscle forms the rotator cuff. We can remember by 6 mnemonic: the supraspinatus, infraspinatus, teres minor, and subscapularis. Okay, the rotator cuff, musculotendinous cuff of the shoulder, all the rotator cuff muscles arises from the scapula and are inserted to the greater and lesser tubercle of the humerus. So all of them takes origin from the scapula. They insert into the tubercles of the humerus. The rotator cuff provides strength all around the shoulder joint except inferiorly. So it is not covering nicely the inferior part of the glenohumeral joint or shoulder joint. Therefore, humeral head dislocation is more common inferiorly because it is not supported by the rotator cuff tendons. Okay, so that's why it is head may be dislocated inferiorly. It may be dislocated posteriorly depending on the type of injury, in some type of epilepsy or bad position in postoperative period that may happen, but usually it dislocates inferiorly. So these are the cuff muscle. We have the origin insertion. Nerve supply action supraspinatus should take origin from the supraspinous fossa of the scapula. Infraspinatus should take origin from the infraspinous fossa of the scapula. Teres minor from the upper 2/3 of the lateral border of the scapula. And the subscapularis takes origin from the subscapular fossa of the scapula that is present anteriorly on the scapula. Insertion, they are inserted into the greater tubercle. Okay, the upper impression for supraspinatus, middle impression for the infraspinatus. For teres minor, it is inserting to the inferior facet of the greater tubercle of the humerus. Okay, so all these three are getting insertion to the humerus, the greater tubercle, upper impression, middle impression, and lower impression. How about subscapularis? Subscapularis takes origin from the subscapular fossa of the scapula. It is inserted to the lesser tubercle of the humerus. Nerve supply, suprascapular nerve, coming from where? From brachial plexus. From which part of brachial plexus? Upper trunk of brachial plexus. Root value C5, C6. Suprascapular nerve also innervates infraspinatus. Teres minor innervated by the axillary nerve, root value C5, C6. From which plexus? Again brachial plexus. From which cord? From the posterior cord. Subscapularis getting innervation, nerve supply from upper and lower subscapular nerve, root value C5, C6, C7. From which plexus? From the brachial plexus. From which cord? from the posterior cord. Action supraspinatus, it initial 15 degree of abduction. The next part is done by the deltoid. Okay, so it initiates abduction, it stabilizes shoulder joint. How? It holds the humeral head in the glenoid cavity. We know that the glenohumeral joint is a ball and socket type of synovial joint. The socket is shallow and the ball is large, so it needs stability. That stability is done by the rotator cuff muscle tendons. Okay, so the sits muscle tendons that provide stability. Like infraspinatus, it laterally rotates the arm, hold the humeral head in glenoid cavity of the scapula. Teres minor, again it laterally rotates arm, hold the humeral head in glenoid cavity of the scapula. Subscapularis, okay, look at that, it is rotating the arm medially. Again it stabilizes the shoulder joint, or you can also call it glenohumeral joint, hold humeral head in the glenoid cavity of the scapula. Okay, we got that. Now we may encounter the rotator cuff injuries. That is not unlikely. Okay, like that of the rotator cuff injuries, may be injured or diseased in elderly person, usually after the age of 40, maybe a patient with diabetes. Okay, or overuse of the shoulder joint, too much overuse. Okay, there may be formation of bony spar in the acromion process. There may be inflammation of the subacromial bursa, maybe bursitis, excessive collection of fluid, or congenitally the gap between the supraspinatus tendon and the acromioclavicular ligament and acromion process is narrow. There may be calcification of the supraspinatus tendon. There may be tendinitis and impingement of supraspinatus tendon. Calcification, it may be removed by needling. We can use the needle to get the calcium out. Rupture of the supraspinatus tendon is also possible. Sometimes it may be asymptomatic. So we are getting this torn supraspinatus tendon. This is an MRI. This is the torn supraspinatus tendon. This is the humeral head. This forms the head of the ball and socket joint. Okay, this is the ball, and socket is the scapular glenoid cavity. Okay, here this is an ultrasonography, a subacromial or subdeltoid bursa. The fluid can be removed by needle here. This is the needle. Okay, this is a deltoid muscle. So it may be inflamed, and it may be managed by giving steroid injection here. This is the ultrasonic feature of the shoulder joint that is detecting the subacromial bursa or subdeltoid bursa. Okay, this ultrasonography may guide the needle to draw fluid or to inject steroid. Okay, there are some tests to identify whether there is any problem in the supraspinatus tendon. Okay, so we have two tests. One is Neer Test and that is Hawkins Test. Neither of the tests are not 100% specific or not 100% sensitive. We have some modification about that. Suppose in Neer Test, we can flex the person's shoulder around 150 degree. Then you can rotate it medially. You can press on the shoulder joint. On the Hawkins Test, we can make 90 degree abduction, okay, abduction, and 90 degree flexion. Okay, we can rotate the arm medially, or we may rotate the arm laterally to, if the patient has pain or patient may have pain there, then this test is positive. Okay, we have some modification of the Neer Test and Hawkins Test, but these are described nicely. Okay, we got that. We can assess the tendinitis or impingement of the supraspinatus tendon or rupture of the supraspinatus tendon by doing the Neer test and the Hawkins test. Okay. And that's all about the rotator cuff. Let us summarize. What are the rotator cuff muscles? These are the seats muscle. What are the seats muscle? Supraspinatus, infraspinatus, and the teres minor and subscapularis muscle. Then we have to know where they take origin. They take origin from the scapula. Where they insert into the tubercle of the humerus. Okay, so on the greater tubercle, supraspinatus, infraspinatus, teres minor. The lesser tubercle, we have insertion of the subscapularis. Nerve supply of subscapularis is the upper nerve supply of the subscapularis is the upper and lower subscapular nerve. Nerve supply of teres minor is axillary nerve, both of them coming out of the posterior cord of the brachial plexus. Nerve supply of supraspinatus, infraspinatus are from the suprascapular nerve that is coming out of the upper trunk of brachial plexus. Okay, and that's all about the anatomy and part of pathology of the rotator cuff muscle and rotator cuff injury or tendinitis. If you have any question, please feel free to ask me. Please share the information with your friends and please support my channel. Please subscribe me. Have a nice day. Bye now.